All right. All right. So medical math. So again, this is just in general, this is medication administration. So at the end of it, at the end of this, the big things that I need you guys to take home, for us to be able to give medications, we have to identify a route that we're going to be able to give the medication. If we find that method, or we find that route that we're going to give it, how much do we give it? Is it the right medication? Is it the right time to give that medication? And basically, do we have all of our boxes checked? Those are kind of our goals in all of this. Towards the end of this, I'll need you to know the different types of medication, the different types of fluid that we can give, the reasons we would give fluid, and then how to calculate how much medication and or fluid we would end up giving through whatever route we've decided. So again, at the core of being a paramedic, we can't do, other than cardiac monitoring, there's very little that we can do that's different than an EMT without this chapter, without vascular access, without being able to calculate the appropriate medications, not overdosing a patient, obviously not killing a patient, and not underdosing them. So there's that medium threshold that we have to try to meet. And once we do that, it's kind of your responsibility to be able to identify all of this stuff, and then turn around and do kind of a follow-up, kind of a secondary assessment, and just overall just make sure what you did had the intended results. And if not, what do you need to change? How do you need to fix that? So there's a lot of problems with vascular access that we're going to kind of get into. A lot of ways you can mess it up, and that's not necessarily super awesome either. So any patient that's hemodynamically unstable, so that to you right now should mean a crappy blood pressure. That to me, or to you, should mean somewhat tachycardic. It's your body trying really, really hard to keep up, but it's having a hard time. So again, the volume is low in the body. The heart is not doing what it's supposed to be doing. So at the end of it, there's no blood pressure. The heart is racing to try to keep up and pump and circulate what blood is in there. But ultimately, hemodynamically unstable patients, these are the sick patients in the sick or not sick spectrum. So again, there's a bunch of different techniques that we're going to end up using, that we're going to end up talking about, and that'll be just shortly here. So what gives us the authority to start shoving needles in people's arms? Well, medical direction, medical control. And again, there is a very, very significant difference between online and offline medical control. So online is your protocol books. That's all the protocols that give you the standing orders to function in the field as a paramedic. It's standing orders that there's a blanket approval that's been given. So if the patient meets these guidelines, then you're more than welcome, X, Y, or Z, then you're more than welcome. You're supposed to be doing, IV access and stuff like that. If it's not online, or if it's not offline rather, and it's something weird, whether it's an off-label use of a medication or whether it's just something that doesn't necessarily make sense to you, that's where the online or the direct medical control comes in. And basically, this is that phone call to the hospital. So again, it's not necessarily just for the approval. It's if something just doesn't make sense to you. If the medical math stuff, if you've got this drug dose and it's in the vial and the math doesn't, it's not even numbers. It doesn't make sense. You don't have a calculator. Just a phone call away. For real life, you call, you get a doc on the line, and they will give you the drug dosing directly. For purposes of testing and stuff within the school, you guys are going to have to figure that out. I can tell you that almost every time you ask, the cell phone battery will be dead, or they're not going to be available, or something like that. Because I do want you guys to be able to figure this stuff out on your own, especially the important, vital, drug doses and stuff like that. But in the field, when in doubt, contact them, call them. They actually would much prefer that. They like to know not only when you're showing up at their ER, but kind of what they're going to get, what you're bringing. So that's kind of important to them. So when we're given the med, again, there's in the resources on Schoology, there's the 6 rights. It's a document. 6 have been expanded to 10. And again, the book goes over it really, really, really well. But we'll also talk about it here. Kind of in some detail, but basically this is making sure that you're giving the right medication to the right patient at the right time. And a lot of times that comes down to standing orders. If you're breaking out the drug bag and you're giving medications, a lot of times there's a reason. It's pretty black and white. They have chest pain. Well, you flip open the chest pain and it tells you exactly what to do. Start an IV, give nitro if their blood pressure is okay. Give pain medication, do a 12 lead. all that stuff. So it's laid out fairly well under the offline standing orders. But again, when in doubt, you call them. Human factors, there are some human factors involved, and a lot of it has to do with the actual technique of starting the IV. So we'll talk about some of that here in a little bit. Here are some of the things, and we're going to kind of go deep into a lot of these kind of as we move through. But at some point, these are some of the big things. Again, dose, drug name, route. The one of the big things is to alleviate the human error is, again, if you have a partner that draws up the medication for you. See, so traditionally, you guys have probably seen it already. The paramedic that's taking care of the patient is going to be sitting next to the patient. The drug bag's not necessarily going to be next to you. It'll be up front, probably with your partner, and you're going to be starting an IV. So as you're starting an IV, you're doing that with the intention of either giving fluid or medication, or you're doing it just to kind of ward off evil spirits, just in case the patient declines and you have to then break open a drug bag. You have access already. So once you're creating the access, or while you're creating the access, your partner's probably drawing up the medication that you intend to give. So this is where the human error comes in. If your partner draws up the wrong medication and hands you a blank syringe or just a clear syringe, you just hope and trust that they gave you the right thing. So again, there's a lot of checks and balances. When they hand you the syringe, they should be handing you the vial also. So that way you can kind of confirm not only how much, but specifically what they gave you. And then we're going to document all this stuff. And I think we know that. By the time it's all said and done, you guys will have a really, really good idea of what this is. You're going to know that you have to document how much you gave. There's a range to almost all the medications that we give. So there's like a minimum, there's a maximum, there's therapeutic dosing, there's a whole host of stuff. You're also not going to give the same dose to me that you would give to a frail 80-year-old elderly female. Those are just different doses. They all fall within the range that you're allowed, the acceptable range, but the therapeutic level is much lower for somebody that's not bigger. Just some things to kind of think about moving forward. So where do these drugs come from? And again, a lot of this is just where we get it, how we give it, a lot of that stuff. Obviously, we've got them in the ambulance. Depending on where you are working, there's drug bag exchanges. So, Miami Valley, they do a really good job at going into the hospital, and they can rotate the actual supplies that they use. I know in like Butler County area, there's an agreement through Westchester, and I don't believe in Hamilton County there's really a whole lot of anything. I could be wrong on that nowadays, but basically the departments, they have one person that purchases all the medications, and the medications, they just get stored somewhere in the firehouses, and they make sure that there's enough of them that they're not expiring and that they're basically ready for use. So this is the big thing that we're going to talk about for starting IVs, this aseptic technique. And this is worth writing down, specifically just the term asepsis or aseptic. That is the sterilization of the equipment, that's cleaning off the skin, that's disinfecting all surfaces in the ambulance, and things like that. That is all super, super, super important for us to create this sterile environment. So the way we're going to kind of do that, sterile technique in general is a deconstruction of all living organisms using heat, gas, or chemicals. Basically, what that means is you're cleaning everything. You're breaking down anything that's living on that surface. So any kind of germs, any kind of issue, whatever's on the surface, deconstruction of all of that is considered a sterile technique. So that's why we wear gloves. That's why we do, we try to keep our procedural areas clean. All of that all goes back to the asepsis process. So there is a difference that we'll talk about between disinfecting and we'll give me just a minute. We'll get back to some of that. So here's the other thing. So ideally, at the beginning of the shift, you're going to go in, you're going to disinfect your ambulance. All the surfaces will be disinfected. Right now, there's probably procedures in place that are actually being followed for the first time in years. Whether we're fogging, whether we're spraying, whether we're wiping down, whatever we're doing it every single shift, and it's like clockwork. Specifically because now there's a problem that we've identified. So for us in the field, we should always start the day with a clean, basically a clean, disinfected ambulance. And I'm a little bit selfish with that because I want that for me. I want it for the patient, but I definitely don't want to work in something dirty. I don't want to see blood droplets on the floor or on the side or on a bench next to you. Certainly don't want to see sharps floating around the ambulance. So all of that stuff is more for me than for anybody. But of course, by reducing the risk to me, I'm reducing the risk to my patients. So trying to maintain that is kind of difficult. You have a non-breather, you have a code, you have a sick patient, you have some run that just quickly just went to hell on you. There's definitely times where that's just not going to happen. A good example of that is like an EpiPen. When you give an EpiPen, you don't have time to sterilize. You don't have time to wipe down the skin with an alcohol prep. And in fact, you don't with an EpiPen, you don't necessarily have time to even remove an article of clothing. You just fire that thing off right through the pants. So, what the difference between what medically clean is and what practical is basically this. You do the best you can with what you got. And sometimes it's just flat out, it's just not possible. But again, it's going to be the best outcome for the patient for us to at least do our best. So here's a big test question, just something to try to kind of understand now. Aseptics are very different than disinfectants. It doesn't sound like a whole lot on the surface, but if you put a disinfectant on the skin, that's a problem. So that's like washing somebody's arm off with bleach. Not super awesome. So again, antiseptics are used on the skin before invasive procedures. So like an alcohol prep or a betadine, or there's a whole bunch of different types out there that we're going to use. But disinfectants are for surfaces that are not living. That's the big difference. So again, aseptics are for people, disinfectants are for things. The most common, again, for the antiseptics, again, the typical isopropyl alcohol that we use. There's some ambulances out west that still use iodine. There's like these ChloraPrep pads that are like 2% chlorhexidine. It's just another chemical that kills a bunch of stuff. And again, disinfectants are more like the bleach and peroxide and stuff like that. Standard precautions, we're still going to do that. Wear gloves, wear PPE. I will mention one thing about the standard precautions. We know that we got to wear gloves. Right now, we know that we should wear goggles and masks and gowns and whatever. But on the typical Tuesday, 3 years from now, standard precaution for an IV is typically going to just be a pair of gloves, and that's what we're going to wear. There's nothing per se wrong with that. The difference is if you do an IV start, there's a chance there's arteries that live somewhat near veins, and you can see where I'm going with this. If you poke the wrong thing, you could absolutely have a mess on your hands. In general, depending on the types of IV catheters that your department uses, some of them don't occlude themselves when you pull the needle out. So we'll know here in a little bit, when you pull the needle out, you essentially have just stuck a straw in somebody's vein to the outside, and it's going to bleed. It's going to bleed under pressure. So that venous blood will just start to go everywhere. Frequently, if you're not careful, that blood ends up usually goes down onto your leg, because that's kind of where you have their arm sitting when you're doing your IV start. It's kind of on your leg when you're sitting next to them. So just some thoughts. Standard precautions does not necessarily mean what you're physically wearing on your body. It can be a towel underneath. It can be some kind of Chuck's pad or something like that underneath, just to catch any blood in the event you decide to do the old ceremonial bloodletting. Disposal. This is the one thing that will get you discommunicated from your entire crew, is leaving a needle floating around the back of an ambulance. This is completely unexcusable. The problem is on the other side, the dichotomy there is on the other side of it. When I stick an IV in somebody's arm and I push off the little catheter, the little straw in the end, that little piece of plastic stays in the vein and the needle has to come out. If I don't want to bleed them all over the ambulance, I lose a hand automatically pushing down and occluding that vein so that blood doesn't come out. So that means within arm's reach from the patient, because one arm is still on the patient holding pressure, I have to do something with that needle. If I'm not close enough, I didn't think ahead, and I don't have a sharps container near me, that's where you have to get kind of creative in what to do with it. 100 years ago, the nasty guys that used to run in some of these, they would just take the needle and stab it into the seat next to them. Well, that's stupid. Let's not do that. Pre-think it. Again, so much of IV is preparation. You guys have probably worked with some medics that are really, really good, or at least in your opinion, really, really good. They're quick. They throw a tourniquet on, they poke the needle in. It is what it is. They've hooked up to the fluid, and you're on to something different. If you've ever had an IV in the hospital, or if you've ever, for God's sake, Children's Hospital is probably one of the worst. It's a whole fiasco to try to start an IV. Not only because kids are less tolerable or less tolerant to this, but on the other side, they're a lot more difficult. The skin's a little bit different. The veins are a little bit smaller. So it is a whole dog and pony show just to start an IV on specifically a kid. So the hospitals take a lot of time in prep. And the prep is because you may only get one shot at this. So take your time, make sure you've got all the supplies that you're going to need, and have them sitting there waiting. And then immediately dispose of everything. The one thing you're going to hear a bunch of is we're never going to recap a needle. That kind of goes without saying, but one of you will absolutely do this at some point. And it's in your mind, it might be the safest. You're going to pull a needle out of somebody's arm. You're going to slide it back into the cap, and then you're going to dispose of it. We don't mess with that. Just get rid of it. Any questions about any of that? That's all pretty straightforward. All right. So fluid. This is the number one reason that we're going to end up putting an IV in somebody is we need to fluid resuscitate them. We need to put fluid back in, whether they're dehydrated, whether they're septic, whether they're having cardiogenic shock issues. Regardless, that is going to ultimately lead to a lower output of circulation in the body. It's also going to lead to a lower electrolyte level in the body, and all of that can alter that homeostasis. So the fluid that we give, there's a whole bunch of different kinds that we're going to talk about here in a minute. And a lot of this you're going to have to write down. But in general, we know that the body is mostly composed of water. We know that lack of water creates all sorts of issues. And not the least is this electrolyte imbalance. And we know, again, between sodium and potassium, we know that those are very, very important electrolytes. Without them, the heart doesn't beat right. And the body in general just doesn't function appropriately. So technically, the definition of dehydration is just a systemic loss of fluid. Really, at the core of it, that's what it is. Their mouth will be dry, their skin will be dry. They'll probably have like poor skin turgor and things like that. And they can have some of this other stuff, but the biggest ones that we're going to look for is specifically, it's going to be a blood pressure. So we use blood pressure. So this postural hypotension, which basically is just regardless of how they're sitting, they are hypotensive. So that's what we're going to pay attention to. And if we notice that, we're going to treat that, and we're going to treat it with fluid. So we'll talk about some of that. So some causes of dehydration, we've all had it. As you're sitting here today, the average American is dehydrated already. So as you're sitting here today, you just woke up. If you haven't drank 8 to 10 ounces of water yet this morning, you're by definition, you are already dehydrated. In general, we're supposed to be consuming about 8 ounces of water an hour. So there's people that carry around gallon jugs of water. They're not just gym rats. That in general, there's a little bit of health benefit to that. But some of the other causes that we're going to see with elderly people is specifically is that they're super sensitive to fluid. So they may have doctors and cardiologists say, hey, I don't want your tank to be full. I don't want your heart to have to beat that hard to force all that fluid around the body. So some of them, they start the day dehydrated and they end the day dehydrated. Now it's not treatable. It's not that bad, but low. So their volume is just low to begin with. High caffeine diet is always funny to me because I drink coffee like it's going out of style. And some of you guys probably do also. So it's definitely a thing. High caffeine diets in general, they make the body work a little bit faster. They make everything work a little bit harder. And all of that creates a byproduct. All of that takes fluid. All of that takes ATP. So your body's physically working just to kind of keep up with that. And then flu-like symptoms, that kind of goes without saying, diarrhea, vomiting. You're losing fluid and you're not able to replenish it fast enough. So these are some of the causes of the dehydration. On the flip side, there's overhydration, which is basically too much fluid. That can cause, shortness of breath. You can hear the crackles or the rails in the lungs. You can have that pedal edema. So you start poking on their cankles down there, and your finger can kind of stay in there. When you let go, there's a big, like a pit that you have that was left over, where literally you just displace fluid with your finger. And you know these people, you may have these people in your family that just have that big swollen ankles, big swollen calves, big swollen feet, and they have to sit down and prop their legs up because, again, there's just an over collection of fluid in there. Now, it is possible to be overhydrated in the interstitial space, which is the ankles and the legs and the feet and that, and still be dehydrated on a systemic or a cellular level. So those are a little more complicated to treat because I need to give them fluid, but I can't give them too much fluid because, again, the body can only handle so much because the heart's typically what those patients are having problems with is their heart being able to pump appropriately. So if the right side of the heart starts to fail, it starts to back up out the right side of the top of the heart, which goes back out kind of to the body. So if the right side of the heart starts to fail, they're going to have this pedal edema. They're going to have this systemic fluid buildup. So again, it's kind of a thin line, but this isn't necessarily referring to that. This is talking about the general person that literally just has too much fluid within the system. So here's what we're going to do. We're going to fix it. There's a bunch of different compositions, and this is actually a good picture and a good time for us to mention it. If you look at this saline bag, there's a lot of information on the saline bag. Obviously, the brand and all the other garbage that we're not ever going to read. There are hash marks that give you how much fluid. This is a liter bag, so there's 1 liter or 1,000 mLs in this bag. They also come in 500s. You'll see those commonly, which is obviously just half size. Some departments carry 250 bags. But generally speaking, you'll probably see the 1 liter bags, the 500 bags, and then there's very, very small 100 ml bags. And that's all stuff that we're gonna see and we're gonna mess with. If you look at the bottom, there's 2 ports. Very important to understand that there's 2 ports, and you may have already seen them. Some of you may know what they do, and a lot of you may not. The longer port on the left. This is where you plug in the end of your drip chamber. You guys have probably done that or seen that. Pull the cap off, you stab the drip chamber up in there. The other one is a big rubber band, and that rubber band is for you to inject medication back up into the bag. So when you're making drips, which we'll talk about later today, sometimes we'll use the 100 ml bags, and we'll fill the 100 ml bags with a medication. We'll shake the bag up a little bit, and literally that entire bag is now a concentrated dose of that medication. And just by using that needle port. So that's really, it's just, like I said, it's just a good picture for us to be able to use. Usually these saline bags are going to be within a sterile bag. So you have to open them from a bag, pull them out of the bag, just to hang the bag and put the drip set and all that stuff in there. So the reason we're doing this, what's in that physical bag is kind of what we're getting into now. So because patients have these altered electrolyte levels, because they've been vomiting, because they have diarrhea, they're going to need something. Usually what ends up happening is the fluid, if you remember from a couple weeks ago, the most common extracellular outside of the cell cation is sodium. So sodium is what's floating around the body freely. That's why sweat tastes like salt. That's why when you end up sweating too much, or when you're too dehydrated because you don't have enough fluid floating around, you can have high levels of potassium, because potassium, that's all that's left in the body. You have sweated out, or you've become dehydrated and you've ridded your body of all the sodium, or a lot of the sodium. So if you notice, a lot of the fluids that we're going to give as it relates to the electrolyte composition is sodium based, and it kind of depends on basically on what you're trying to achieve. And that's something that we're going to kind of talk about here. What's important to see on this, and we'll talk about it a little bit more in depth, the human plasma. So this is the fluid that's floating around the body already. So 135 to 145 milliequivalents, which is just a fancy term for just a unit of measurement that they like to use. So if you look, the closest thing to that is that lactated ringer. The problem with the lactated ringer is that it doesn't necessarily meet the criteria for calcium, magnesium, for anything else. The other problem with lactated ringers, there's not always We don't always have that ability to carry this for cost purposes and for some other reasons that we'll talk about here in just a minute. The one that you're going to see the most common is the 0.9%. That is your normal bag of saline. That is the closest to normal blood as it relates to the sodium level that's out there. So that is what we use. That is, so the 0.9% is what's in all of our saline bags. The 3%. So knowing what you know now about fluid, the actual liquid part of fluid, or the plasma, that is drawn to sodium. So again, kind of backing up a couple weeks, if you eat a whole bunch of salt today, you wake up tomorrow with a dry mouth and dehydrated and all that, because again, all of that sodium that's in the body floating around is pulling all the fluid out of all the cells, because again, water likes sodium, and sodium attracts water. So if I tell you that you're extremely dehydrated, if I put 3% sodium chloride in your body, that's going to dehydrate you worse. That's going to make things worse. If we shifted gears, and I told you that we had a traumatic brain injury patient. So this patient, bad car wreck, smashed his face on the A post of the car, and you're treating them, and they have a traumatic brain injury. That brain injury is literally a result of swelling. So all of those cells are starting to bulge and overflow with fluid. So within them cells, again, that's not necessarily good to retain that much fluid, because again, that's swelling and inflammation, and we know that that's no good in a brain. So you can kind of see where I'm going with this. If you have all the fluid, if you want to try to pull that fluid out of there, 3% is an option, because we're giving a solution that is going to attract that water out of the cells and into the bloodstream. So these traumatic brain injury patients, it's not uncommon for them to get this 3% sodium chloride, because again, it pulls that swelling away. It pulls that fluid out of there to prevent swelling further. Does everyone kind of understand that? All right. So the 0.9 is something that we, like I said, that is the closest, the closest to equal on all levels. And we'll talk a little bit about that right about now. All right, first definition.
Hey, Adam, real quick. You would only use the 3% for a TBI. You wouldn't do that to like slow down a hemorrhage in the head or anything?
So that's correct. What I'm trying to accomplish with the 3% is I'm trying to pull fluid out of the cells. Generally speaking, you don't ever want to do that. Generally speaking, you want those cells to be as full as they need to be to function. With those traumatic brain swells, that injury where the brain tissue is just swelling and swelling and swelling, the 3% is going to draw that fluid some sort of out of there. If they're bleeding out, again, that's kind of an unrelated. That blood loss is you losing sodium from the body, which ultimately 3%, that might not be that might not be a bad thing, because again, if they're bleeding all over the ground, they're losing a significant amount of sodium from their body anyway. But in the field, we don't typically do that, because we don't necessarily want to dehydrate the rest of the body to try to combat, whatever the actual insult is. So again, the only time you're really going to see this 3% used is with brain injuries. And actually there's a whole lot of studies out there that say that that's even dangerous, because again, how do you qualify that, or how do you quantify that? Every person's a little bit different. And without a scanner, I can't tell how swollen the brain is. All I know is that if it continues to swell, at some point it's going to herniate. It's going to push down through that foramen magnum, and that's fatal, because it compresses the brain stem. So when your brain swells out of the little hole in the base of the skull, again, that's fatal. So our goal with the 3% is to pull the fluid off as a life-saving, option before they get to that particular point. So the first one we're going to talk about is the crystalloid. The crystalloid is the most common type of solution that we're going to use. There's crystalloid, there's colloid, and we'll talk about in the next couple slides. But the thing to know specifically about crystalloid is that it is able to cross the membrane and alter fluid levels within the cells. So those crystals dissolve. That dissolved crystal, or the salt or the sodium, the fluid, what makes that solution a solution, is able to go back and forth into the cells. That is really, really, really important to understand. So crystalloid can travel through the membrane and into the cells. Now, it's not plasma, it's not hemoglobin, it's not red cells. It cannot carry oxygen. So when somebody's bleeding out all over the place and I pump them full of normal saline, which by the way, normal saline is a crystalloid solution. If I pump them full of normal saline, that's not necessarily helping their perfusion. It's just helping the volume in their body. That's really, really important to understand. So me giving them all this fluid does not help their oxygenation status, not even in the slightest, because it does not carry oxygen. So the opposite of a crystalloid is a colloid. A colloid, the molecules are too big to go into the capillaries or into the cells or anywhere else for that matter. This is literally just a fluid replacement. We're never going to use these. This is not something that we're traditionally going to do in the field. This is something that they're going to give for patients that already have edema. So this is that complex case I was talking about earlier, where they have right-sided heart failure, they have swelling distally, they've got all this fluid accumulation outside of the cells and outside of the vascular system. They call that interstitial. So in the interstitial space, which is just the fatty areas, down usually distally because of gravity. So around the feet and the ankles, these are the cankle people. So those patients, again, they can still become cellular. They can still have cellular dehydration and still have that fluid accumulation. So if we start pumping them full of the crystalloids or our typical saline, again, that is able to go back and forth and travel kind of wherever it wants. And it's going to go to the path of least resistance. So it'll fall into the lungs. The lungs will start to absorb it. The feet and the ankles, they'll start to absorb it. So again, you're further complicating their problem. So colloids, the particulates inside are too big to be able to pass through that membrane. So again, this is strictly for vascular system dehydration or vascular system, just volume really is what it is. This is just a volume replacement. Does that make sense between the two? All right. So these are crystalloids. So we're back to crystalloids. So the crystalloids, again, I'm not going to talk anymore about these colloids because again, we're not really going to use them. There's no way for me to tell, in the field without labs where I need to send the fluid. If we're giving them fluid, it's because they need volume, but they also need the electrolytes that go with it. So again, this is important to know, but now it's time to put this out of your brain. So we're going to go from these crystalloids to the different types of crystalloids. Now, I can also say the colloids that we're not going to talk about a whole lot, they can also be these three categories, but not, again, traditionally we're referring to just these crystalloids that we use on a regular basis, which again is normal saline. Normal saline is the most common crystalloid. So here's three more definitions that we have to understand. So isotonic basically means when you see the term or the prefix iso, as it relates to this, as it relates to cardiology, as it relates to anything, iso is neutral. So it's just a flat line right in the dead center of everything. With a heart rhythm, we talk about an isoelectric line, which is that baseline that we're talking about, where the heart will either send a little wave up or send a wave down. But there is an isoelectric line, which is the neutral baseline. So neutral baseline for fluid is a fluid that can kind of go wherever it wants. It can go in the cells. It can go out of the cells. It doesn't particularly matter. It can kind of travel to wherever the volume is needed. So that is what our normal saline is, because that's exactly what it does. It doesn't necessarily shift a whole lot. It doesn't change the shape of the cell. When the cell's full, it just no longer can go in there because it's full. So it'll float around somewhere else. It is the most benign, easy to use fluid out there. So hypertonic, the first one, so hypertonic has a greater concentration of sodium. So if I'm giving fluid that has high sodium, you're going to be pulling fluid out of the cells because, again, water and fluid, they're attracted to sodium. So if I'm giving sodium high concentrations, this is at 3%. So I'm giving that 3%, it's going to end up pulling fluid out of the cells, kind of like what we talked about earlier, because again, that water wants to go to that sodium. So Please, please, please make sure you understand that. So isotonic is free range, can do whatever it wants. Hypertonic is high in sodium, which draws fluid from the cells. Conversely, hypotonic is very, very low. It's very, very low in sodium, and it's much lower than the cell. So the cell has more sodium in it, and it draws that fluid into the cells. Does that sort of make sense? All right. So the downside, or the scary part about the hypotonic solution, again, it can do that, and it never knows when to stop. It will continue to draw water into the cell as long as there's a sodium supply that's higher on the inside than on the outside. So at some point, those cells can swell, and ultimately those cells can burst because they literally cannot hold any more fluid. But the sodium level inside the cell is higher than the sodium level outside of the cell. So that's a really, really dangerous medication for that specific reason. It can increase the intracellular pressures to the point where they literally can expand and blow up. Again, no good. Any questions on that? None. Good. So here's our examples. So isotonic, these are traditionally what we're going to use. These are the 0.9% sodium chlorides that we use. Lactated ringers, again, there's some other ones. Some places carry D5. D5, again, the 5, the D50, the D25, the number after the D specifically talks about the percentage of dextrose that's physically in the water. So people that are in the ICU that don't have a typical diet, or they're on some kind of dietary restrictions, they need sugar. The brain literally needs two things to operate: sugar and oxygen. That's it. Those are the only two things that a brain needs. So if they can't eat for some reason, or they have some kind of weird dietary restriction, it's not uncommon for them to be able to, or to have a D5, some kind of drip hung in a saline bag, just to keep that sugar, keep that dextrose moving throughout the body. Lactated ringers, the other side of that, lactate, the first part of that is acid. So in general, it's somewhat of an acidotic solution. There can be a whole host of other problems that can negatively affect the liver. It can be detrimental to like blood transfusion patients, and there's a whole bunch of different reasons. But there's a lot of people that'll tell you that lactated ringers and normal saline are the same. They are not. They are absolutely not the same. So again, it's something. It's something that they can ultimately get, a patient can get if they've lost like a significant amount of blood. That would be indicated for lactated ringer. And for us to understand anything about lactated ringers, that is the only solution. That's the only point that I would make, is that patients with significant blood loss should probably get this. Not going to help us in the field because we don't carry it, so it's not necessarily going to matter. There's also all kinds of contraindications to it. If you give them nitroglycerin or something, there's a whole host of them. So again, it's not a benign fluid like sodium, like our normal saline is. Any questions on that?
Yeah, I have a question. In the book, it says it's a hypotonic solution.
That what?
It's 5% dextrose in water.
Really?
On page 693.
That's a really good point. That's an interesting point. You said it's listed as a what?
So on 693 under isotonic solutions, so it's under isotonic, but then it says isotonic, hypotonic, and then it says D5.
Oh, I see what you're saying. Yeah, that's really strange. No, yeah, it is absolutely it's an iso. It is definitely an isotonic, which is kind of interesting that the book says it kind of weird like that. That's a good point. Thank you. Yeah, no, it's try to keep in mind as an isotonic, because again, the isotonic side of this refers to how much sodium. So again, it can kind of move kind of free range. If sugar can't get into the cells, it's essentially useless anyway. So if you think about it from that perspective, if it's hypotonic, Well, I guess there is an argument that if it was hypotonic, then yes, the cells would draw it in a little bit quicker. So yeah, that's a really, really good argument, and I don't have a good answer.
Hey, Adam, on the next page, it explains that. It says D5, dextrose in water, is a unique type of isotonic solution. As long as it remains in the bag, it's isotonic. Once administered, however, the dextrose is quickly metabolized and the solution becomes hypotonic.
That's awesome. I did not know that. God, you guys are awesome. Yeah, that's a good catch. So I guess that does make sense. Hopefully that makes sense. I would want D5, any kind of dextrose. Again, I would want that to be hypotonic because again, I want the cells to take it all. So yeah, that would make sense. It's interesting that it can do that. Well, good. Thank you, Savannah. That's awesome. Awesome. Any questions about that? If so, you can email Savannah. She'll have it all figured out for you, I hope. All right, where are we here? So again, normal saline, that is the number one isotonic solution that we're going to use. So just keep that in mind because that's important for you to understand. So hypotonic solutions, we talked about that. This is the solution. It has less sodium than the cells, so the cells are going to kind of take the fluid in. Hypertonic's the opposite. It's going to draw fluid out of the cells. So again, that middle point is the big one. It's going to stabilize the blood pressure because it's going to help equalize. It's going to pull some of that extra cell fluid out, increasing the urine output because you have pulled more fluid into the bloodstream. It's going to reduce edema because again, it's going to pull that interstitial fluid back into the system. And absolutely, it's possible for you to overdo it. And if you overdo it, again, the cells won't have enough sodium within them to function either. So again, use with caution. The biggest indication in the paramedicine world is going to be these head injury patients. And this is where that 3% falls. So oxygen carrying solutions, this is a whole nother story. This is not saline. This is not ringers. This is not fluid. This is strictly whole blood. Now, there's a whole lot of other things that we can talk about as it relates to whole blood. Specifically in the field, we can't really do it because it has to stay thermoregulated. So that it has to be refrigerated. It has to be, blood products in general are very, very unstable on a shelf. So in general, we're probably not going to see this. What we might see is what the military is doing, and that's packed red blood cells. This packed red blood cells is basically they'll dissolve all the plasma, and you're left with like a powder, and that powder is literally like actual blood. They'll dehydrate it, so you end up with just this solid. They'll reconstitute it with saline and then send it back in the body. They'll reconstitute it with plasma and send it back into the body. These are just different options that they're trying to look at for military, for being able to get blood products without physically carrying a refrigerator or some ability to thermoregulate them. All right. Any questions on that?
Adam, I do have one question. This is kind of off that. Going with blood, why would you have blood at a 60 drop in a micro? Because isn't blood large? Doesn't need a large bore? But up north, we're required to have a 60 drop micro, which makes no sense to me. Your thoughts?
The answer for that, I really don't. I don't have a good answer for that at all. The traditionally we're going to look at the micro drips. We're going to look at the macro drips, and we're going to look at the difference between them. In micro drips, which is that 60 drip set, it takes 60 drips of fluid to make 1 ml. So you're going to use that when you need some kind of hyper control over how much fluid you're actually giving or how much medication you're actually giving. So as a result, as it relates to blood, again, you're right. That's kind of counterproductive. I know Air Care carries both. They carry I think it's a 5. It might be a 5 drip set. So they're these monster drips that come out of that drip chamber to again be able to reperfuse quickly. In general, we don't necessarily like to reperfuse quickly, specifically with something that has the properties that blood does. So when you're doing any kind of transfusion, or when you're doing, which we're not going to do, but anytime somebody undergoes some kind of organ transplant, they have some kind of transfusion therapy in there, the body does not like reperfusing blood quickly, and that's the only medicinal reason that I can think of that they would want to use a 60 drip set is just to slow the process. Again, the body tolerates fluid very, very well. Specifically when it's isotonic fluid, it loves it. It doesn't affect it whatsoever. But again, you start sending something in that has floating particulate in it, red blood cells, white blood cells, those leukocytes, all the little things that actually go into the plasma or into the blood. The body wants to fight that. So they'll have some kind of systemic reaction if you infuse that quicker than it can tolerate it, if that makes sense. So medicinally, that's the only reason I can think of that you would want to slow that down. And again, it sounds like it would kind of create some problems all to itself, because blood by nature has a coagulopathy. It likes to coagulate. It likes to clot. So, if you have a really, really, really tiny orifice that you're trying to drip blood through, it wouldn't be uncommon for me to think that would clog and stop. So I'll look at that on a break, because that's a good question too.
Thank you.
What else? Anybody else? Got anything else? We're going to take a little break. Take 5 or 10, and we'll come back and we'll go over some of the IV and IO administration stuff. So like I was saying before, a lot of this is going to be technique that we're going to learn in lab, and I don't necessarily want to go way deep into the physical stuff if you can't physically do it just yet. So we're gonna breeze through some of it, make up some time, and then we'll do some math stuff. So IV therapy. IV therapy involves cannulating a vein. So again, the part that goes, if you're at work and you happen to have access to an IV catheter, play around with it, figure out how it works, look at it, figure out how you can extend and push off the actual catheter end. We'll talk about some of the different anatomy pieces of that here moving forward in this lecture. But just in general, we're cannulating a vein, so we're getting access within the vein. Everything needs to stay sterile. Again, I'm going to move through this pretty quick. Here's some of the stuff you need. A lot of this stuff is commercially packaged together, so you need some kind of tourniquet. Some kind of aseptic wipe, gauze just in case you miss, a couple pieces of tape to secure it when you're done. You'll need the catheter itself, and an administration set or a drip set. So those are the key components to that. Hopefully we've all started them. You should have done it in EMT school. Some classes didn't do that for some reason, but hopefully you've at least seen it or seen this process done. Here's the different bags that we talked about. The 250s we don't typically see. Instead, it goes from 500 usually to 100 with pre-hospital care, because again, it has to do with drug dosing specifically. Usually lactated ringers or normal saline is carried. We've already determined that lactated ringers aren't the best because they do have some negative, some downside to it. And the people that hang a bag plan to start an IV in the ambulance and then leave and go home and leave the IV bag, I can't stand. It's just a pet peeve of mine for some reason, but it happens everywhere. If you don't use it and it's still clean and it's still aseptic, there's no reason that it can't hang for 24 hours. But technically 24 hours of that fluid sitting in that drip set, it needs to go. And again, I don't necessarily want an IV bag that's been hung, yet by yesterday's crew for whatever reason. So generally I'd rather waste it than to hang it and try to reuse it. If you're somewhere really busy, that's different. That's a different story where you think you'll use it sometime later. Feel free. And again, we're referring to the patients where we need IV fluids, but for some reason we couldn't get the IV. We either failed or there was some other issue. And we never ended up using the bag, even though we hung it and prepped it. The drip chamber. So at the bottom of this, let's see, there's not a good picture here. But again, we're going to spike the IV bag, which is something that we all should have done. You put this through, you use the piercing spike, you go up through the bottom of the bag, you squeeze the drip chamber to fill it about halfway full, which is exactly what we want. We want it about halfway full. Here's a photo difference of a micro drip that has this little metal pin in it and a macro drip that doesn't. These are the big differences. These micro drips we're only going to use in the field for one specific type of medication. So you'll probably only have one of these, and you may not even know where it's at right now in the ambulances. But it should be with the dopamine. But again, this has to do with a very, very fine controlled delivery of a medication. Otherwise, this macro drip, just let her eat. That's what we're going to do. So this is the one we're going to use. This is a 10 drip set. The GTT per milliliter is very, very important for us to understand. GTT per milliliter basically means that it takes that many drips to get 1 ml. So with the micro, it takes 60 drips. You can sit and count 60 drips. And for every 60 drips, that's 1 ml of fluid that's made it to the patient. Conversely, the macro drip, it takes 10 drips. So 10 drops will equal 1 ml or 15 or 20 or whatever you carry. Your ambulance should have one or two 60 drip sets or 60 drop sets. And again, that's for one specific med. And by and large, you should all be using the 10. So for purposes of math and stuff moving forward, micro is 60, macro is 10. And that's what we're going to end up using because again, that's what most of our practices carry. Any questions on that? All right. So you're going to prepare it. You're going to flow fluid through the drip set until it comes out the other end. You're going to clot it off, or you're going to wheel it off to stop it. You're going to check the expiration date of the fluid. You're going to make sure the fluid's clear. You're going to make sure that you're hanging what you think you're hanging, so it's saline and not some 3% or something else that you might have confused in your ambulance. And then you're going to start getting all your other stuff together. So on the bench seat next to me, I like to put all of this stuff. This will all sit on the bench next to me, all open, all ready to go. If you're fortunate enough to have a department that has actual prepared sets, within the set, there's like a foldable, it's just a clean pad that you can lay down and put all this stuff on top of, knowing that it's sterile, it's 100% sterile. And then basically you pull off your tape, and we'll go through all this stuff, but you want to make sure everything is set up and ready to go before you physically put that tourniquet on the patient. So then you're going to look for an IV site. If you're this person, you shouldn't have any problems whatsoever. If you're a 90-year-old overweight male, you're probably going to have nothing that looks anything remotely similar to this. So we're looking for the main areas. In the book will start to identify some of the main areas, and so will this PowerPoint. But basically, we're looking for the straightest vein possible. We don't necessarily want to pick a site anywhere that's on the medial side of the wrist. There's some important vascular stuff that lives there, and nerves. So we don't traditionally go in the wrist, in the center or the bottom of the wrist. Anyway, we usually we'll look for something that's nice and straight, that doesn't end up changing around. Here, let me see if I can get my pointer out. It's not liking me today. There it goes. Hopefully everybody can see the pointer here. So this is a nice straight road right here. There's nothing wrong with this whatsoever. The higher you go into the crease of the arm, this antecubital area here, we're going to talk a lot of, I guess we're going to talk a fair amount about that. But all of these up here in the actual bend of the arm are awesome. They're all ideal. Right in here, I wouldn't necessarily think about trying to start one there. Because again, there's different valves in here that allow the blood flow to go down these different channels. Naturally, if you start an IV line here, you know that you're going to end up having this weird 90-degree bend, and that plastic catheter is not going to like that very well. So my ideal spot would be right here on this person, because it's not super close to the skin. It's a nice big vein that I can kind of see and track all the way through, and it's nice and straight. So I would probably poke somewhere right in here and go straight up. I'd feed straight up into there. You can also use the other side of this vein on the inside of the wrist. So the inside of the wrist is a really, really awesome spot. Something a lot of people don't think about, if you're looking and you don't necessarily see anything close, obviously that's what the tourniquet's for. It's gonna let these kind of engorge a little bit. But if you're looking for a spot and you just can't find one, underneath the watch. So if somebody traditionally wears a watch on their left side of the wrist, that skin, because it sits under a watch most of the day, the skin itself here is very, very thin. And this is usually a really, really good spot to find an IV location, just on the inside of the wrist underneath the watch. So just some things to think about for that. But you're gonna look for something straight. You're gonna feel it. At some point here, you're gonna go ahead and you're gonna put the tourniquet on. And when you put the tourniquet on, it's gonna again, all of these are going to engorge and they're going to solidify. It's going to be a lot harder. So when you touch them, the goal is, and again, we're going to do this on each other. But the at least finding a site, but the goal is to be able to feel, and what you're feeling for is a rubber band. It almost feels like if you pull a rubber band tight and you start pushing down on the top of the rubber band, that's exactly what a vein should feel like. If you don't feel that very distinct rubber band, that rubbery feel, that's probably not going to be a vein. I've got a whole lot of tricks that we're going to do, or that we're going to see, to be able to fine tune this. But this is absolutely an acquired skill. It's not something you're going to be super awesome with at first. There's going to be a lot of time for us to practice, though. So these cubital areas here, again, these are kind of the areas that we're going to want to focus on. This is ideal. This is probably a good starting point. This is why you see most medics put stuff here. But again, this one right here, right off the bat, I don't like this because it bifurcates here. So you'd have two different directions. So I would probably go out here to this lateral one, and this would probably be my choice here. Otherwise, we would have to do this inside of the wrist one. Now remember, this is just showing you veins. There's also arteries that kind of live and kind of run through here very similar. So if I put a tourniquet on somebody's arm and I reach down and I'm feeling it and I feel a pulse in it, generally speaking, that's frowned upon. So we don't want to poke on something that's pulsating. So just kind of some food for thought. Now, here's the other thing. So this is the most common right in here, this cubital area here. The second most common is somewhere down here in the wrist and hand. That doesn't mean you can't start an IV in the bicep or in the forearm or wherever in the neck. And we'll talk about that here in a little bit. It just means these are ideal because they're usually superficial. They're usually on the top of the skin. You don't have to go digging. You can usually see them. And the other thing to think about, since I mentioned it, when I went through, and when most medics that have been around for a little while, they wanted you to be able to find these blindfolded. So the problem nowadays is that if you look at somebody's arm and you don't see something that looks like this, immediately it's like, well, I don't know, I'm not going to be able to get that. I'm not going to be able to feel that. The sense of feel is gone. Some of the old school nurses, you'll see they still rip a finger off of their glove so that they can poke and touch and feel. And there's nothing worse than doing that, specifically from the aseptic technique point of view. That is just contaminating that whole spot. So and not to mention it's not safe for you, but so that's not ideal. But if you're going through and you're feeling around, you should be able to feel that rubber band. And again, it's just going to take practice. It's going to take you picking whatever finger you're going to use and using the same finger all the time for the rest of your career, because you know what that sensation feels like. So for me, I usually have an IV in my right hand. So usually my right index finger is what I'm palpating. That's what I'm using to kind of feel around. So my left index finger rather has, I for sure, I know that the sensitivity, I know my body, I know that finger. So I can feel, and I know when I feel what I'm looking for. So that's just to get in a good habit of things now is going to be very, very important for us. So bulging veins, things that are real close to the surface aren't necessarily anchored into tissue. They're just floating around on the top, which is another reason why these superficial ones, or the ones on the top, aren't necessarily awesome. There's one part of the technique. Once you find, so you've identified, you put the tourniquet on, you've identified that spot. Let's just say, let's just say we want to poke right here, and we want to feed that catheter up through this area right here. Knowing that this vein is going to move and roll around, this practitioner just took thumb, made him make a fist, and stretched the skin down. So when you're doing something, you want to push down and stretch the skin and make sure that it's very, very tight. And what that does is it kind of locks in that vein. You want to physically grab a hold of that thing if you can, push down and drag it, and physically pull it tight so that it doesn't roll around on you when you poke them. And again, a lot of this is stuff that we're just going to physically do, and you'll be able to you'll get it. You'll know what I'm talking about. So you've selected a site. I'm going to skip ahead. Generally speaking, I'm going to go back to this. Generally speaking, we don't like to start IVs on feet. Generally speaking, because these are very, very sensitive. It's sensitive areas, but the vascular system itself is not super profound. So you're dealing with little tiny veins. You're dealing with sometimes very, very poor circulation. With diabetic patients, there's some kind of there's usually neuropathy down here where they can't really feel anything anyway. Blood flow is all constricted to this area. So this is generally too far from the heart and just not a good place to go anyway. So I would stick to the upper extremities if you can, or the internal jugular. That'll be the other one that we end up, or the external jugular rather. Or we'll end up hitting those. Questions on that? Moving forward. So the techniques, this is one option for one of the IV catheters. There are hundreds and hundreds and hundreds of different types, but all of them will have the same couple things. There's going to be a plastic catheter down here at the end. There's going to be a hub, this little hub right here, and that is color dependent on size. There's a needle or a trochanter that goes down through the middle here. And then there's usually a drip chamber or some kind of flash chamber. So as soon as this makes it into a vein, you're going to see blood. Since this is all clear right here, you'll actually see blood go up this. You'll see it fill this, and then you'll see it travel all the way up through here. And in this particular one, you'll see it fill in this little drip chamber right here. These are butterflies. We don't use these in the field. These are usually for specifically for drawing blood, and we do have to talk about that because this is a national course. But we don't do that in this particular area anymore. Some of the newer needles are tracked by a push of a button. Some of the newer needles, as soon as you stick it in the skin and you push the catheter off into the vein, the actual catheter within the hub, there's a little door that shuts, and it basically occludes itself. Those are super, super awesome. But again, the cost is usually an issue with a lot of the departments. So when you're looking at an IV, there is a bevel. The bevel is, there's a good picture of it coming up. There is a bevel that is basically an opening at the top of the needle. That always goes to the top. So you keep that up. You maintain traction, which means you're just physically pulling on the skin, and you're directly underneath the constricting band. And again, this is just procedural stuff that we're going to go through. IV, we talked about tourniquets, cleaning and prepping the site. So when you prep the site, the test question that you're going to see about this, when you prep a site, you always do circles. So you actually clean this area. You start with little tiny circles, getting bigger and bigger and bigger and bigger and bigger. And then once you've thoroughly done that and you've cleaned that site, you never touch it again with your fingers. You can touch below it because you're going to have to pull traction and pull that vein or pull that skin tight. But generally, again, you start at the dead center where you're going to poke and start to make little circles moving outward. I'll show. Let's look at a video real quick of all of this because I think that's going to be easiest. And as always, the videos are already in Schoology. Going to YouTube, sorry. So you guys will have access to these. There's actually a lot in this resource section. I dumped all kinds of stuff into this just because there's a lot to know, a lot of stuff to do. Man, there's an ad in the background just going to work. Standby one. You guys probably want sound.
Okay, so you're at the point where you need to start an IV. If you aren't comfortable yet starting IVs, the most important thing to do is not to panic. If you go into starting an IV with a confident attitude, this process will go a lot smoother. You want to have all of your supplies ready before jumping in. The supplies that you will need include gloves, a beveled needle with catheter, an IV start kit, which typically includes a Tegaderm, gauze, a skin prep cleaning agent, tape, and a tourniquet. We have all those things laid out on our table. You may also need a 10 milliliter saline flush, which you'll see in a little bit, and is used to determine whether you are in the correct location and determining your vein patency. You may want to also tear your tape into strips and attach them to the side of the table so you'll be completely prepared to tape your IV in place. To begin, you'll want to find a suitable vein. There are numerous veins that can be poked, but the most common veins are located on the upper extremity, mainly the antecubital fossa and the dorsum of the hand. Now, there are a lot of tricks out there that seasoned IV veterans use to make veins bulge out, but a few of the more common ones are to ask the patient to clench and unclench their hand into a fist. Do this for approximately 10 seconds. Another trick you could use is to have the patient's hand and arm down by their side so that gravity pulls the blood down into the extremity. Notice he's also clenching and unclenching his fist, doing both tricks at once. Some people prefer to tap a vein, which may reveal a good vein and get them to stick up. Don't spend too long looking for a good site, since patients expect you to know what you are doing even when you may not be a pro. Now let's begin with an IV start. To begin, you'll need to apply a tourniquet. There's no magic location on where to place the tourniquet, but as a rule of thumb, you want to apply it in half an extremity proximal to the puncture location. So it's half up the extremity proximal to the dorsum of the hand, which is where our IV start will take place. If you were to start an IV on the antecubital fossa, which you can see in another one of our videos, you'll want to tie off your tourniquet at the middle of the humerus. Now, there are many modifications to the tourniquet tie, but you want to make sure you tie it so that it can be released with one hand. We just demonstrated one version of the tie, so that if you pull on either one of these ends here, that tourniquet will come loose. You'll want to tie the tourniquet tight enough to impede any venous blood flow, but not too tight as to amputate their arm. Nice. So now step one is complete. You'll want to cleanse the skin over where you will introduce the needle. This is to prevent any infection once you break the skin surface. Once you have found your vein, you'll most likely want to anchor it. Now that the vein's clean, we'll anchor it. Veins are mobile and tend to roll around, so anchoring a vein will help you when inserting the needle. To do this, as you just saw, we will grab with our non-dominant hand a few inches distal to the vein. With our thumb, we will apply some skin traction distal to the site, meaning you are dragging the skin away from the site of puncture. This reduces the number of whorled veins and will make you look like a seasoned IV start veteran. Now it's time to grab your needle and a catheter. These come together in your kit. The important thing to remember here is to keep the bevel up. What does that mean? Well, here's a little graphic. You can see that the bevel, referring to this diagonal portion of the needle, is facing up, away from the skin. You want to maintain that all the way through your puncture. With your dominant hand, you'll want to keep the pointed side down closer to the skin, with the rounded side or bevel facing up to the ceiling. This will allow the needle to pass easily through the skin and into a vein. The next trick is to figure out an angle. You don't want to stick the needle in the arm at a 45-degree angle, because we are not digging for gold, we are digging for a vein. This could be very dangerous to the tissues underneath the vein if you have it at a too extreme of an angle. Veins are pretty superficial, so it won't take long before you encounter one. I typically hold the needle at a 15 to 20 degree angle, as you can see here. Make sure you insert the needle in a nice and controlled fashion. Once you hit a vein, there will be a little flash chamber that will fill red. As you can see there, red is filling the flash chamber. This tells you that you have indeed pierced a vein. If you're in the correct location, your next step is to advance the catheter off of the needle with your opposite hand. Remember not to move the needle, you are advancing just the catheter. Ideally, you'd be able to move the catheter all the way up to the skin surface, like so. Sometimes this is more difficult than others. We are simply sliding the tubing off the needle there, and after you advance the catheter...
A couple things I want to mention real quick. Just on page 704 of your textbook, it says that you should use a 45-degree angle. I disagree with the textbook. I agree with this guy. If you go too steep, the point at the end of that bevel will end up going through the other end of the vein. So basically you'll pierce through both sides, and you don't really have a whole lot of control. So the shallow angle or a shallower angle gives you a lot more room within the vein to stop and notice that you've got that flash. A lot of times it takes just a second for that flash to make it out of the vein up the tubing so that you can visually see it. There's people that do these so quickly that a lot of times they do it off of sense rather than fill in a drip chamber. They just know they're in. We're not there yet. We're going to rely on being able to visually see that fluid chamber fill up. So the first poke, getting that bevel into the skin, is the painful part. Once you're in there, the only thing painful to the patient is going to be residual pain from the initial poke and you digging around. So the second you clear the skin, or the second you get into the skin, the first layer of the skin, and you're in the arm, that the initial pain is there and subsiding. So from there, you can go a little bit slower to try to slowly make sure that you don't go and pierce through both sides of the vein. That is the number one way to infiltrate an IV, is to go too steep, too quickly, and poke through the bottom. You go through the top and then through the bottom, and you're basically all the way through. You've harpooned that vein. The other thing that I want you to note is this guy gets paid to make these videos. And if you notice, we're no longer in the hand. We're in the AC now. We're in that antecubital fossa area. It's because on the hand, if you noticed, he missed it. It wouldn't slide off. So even professionals that make money making videos, they still posted it, which I still think is kind of strange that they posted a failed IV attempt, but that was 100% a failed IV attempt. So they moved sites. Now they're up in the arm. The other thing I want you to know is you can tell that the blood is getting ready. As soon as this needle comes out, there's a possibility that this bleeding will end up dropping out onto the arm. That's not necessarily a bad thing. That happens, and I promise you it's going to happen. The technique that he's using to occlude that vein, I don't like whatsoever. So if you can, hopefully you can see my cursor, but if you can see, there's the straw, the actual plastic catheter piece. It goes down into the arm and it stops somewhere right about here. So what he's done, he knows exactly how long this catheter is. And the whole idea is that he has pushed down right on the very tip of that catheter within the vein. And basically what that's done is that's stopped blood flow from going up that cannula, up that straw. We're not going to know right off the bat. We're going to be focused on what we're doing with our right hand, that we're not necessarily going to pay much attention to the left hand. And this is where this ceremonial bloodletting happens. The whole vampire stuff happens here, and blood goes everywhere. Instead of using a thumb, I would prefer you guys use your first 3 fingers. So if you put your first finger, your index finger, from your left hand, if you're left-handed, your right hand, your non-dominant hand, if you want to stick your first finger right at the hub where it enters the skin, and then your second finger will obviously just put them together and push down with all 3 fingers. What'll end up happening is your third finger will happen to land right about where his thumb is. So this takes the guesswork out of how far back. Because once they start bleeding, you end up panicking. And once you end up panicking, you lose all fine motor control to do this anyway. So the easiest thing to do is use 3 fingers and start at the hub, and 1, 2, and 3, and your third finger will automatically end where his thumb is. So that is how you occlude the vein from spewing blood all over the place.
All the way up to the skin, you can remove the needle. Some needles, like the one here, are spring-loaded, so they will retract with a simple button push. After we do this, we will need to stop the blood and stop the bleed. As you can see here, blood has started to come out of our catheter. You can notice that our practitioner has applied pressure proximal to where the catheter enters the skin, thus impeding flow out through the catheter. Next, the practitioner will remove the tourniquet with the one-handed technique, like so. And now the practitioner will check the patency of the vein using 10 milliliters of saline in what's called a saline flush. They will screw.
Now with this, we're not going to do this either. We will have a drip set on the end of this. So we'll either have a drip set that's connected to an actual bag of saline, or on page 706, there'll be a small saline lock, which is just a small little loop that we've pre-flushed with fluid. We'll screw that onto here, and that will prevent us from leaving this open and able to be contaminated in the air. So generally speaking, again, we don't want to screw anything directly to it, because that means next you have to unscrew this, re-occlude. There's another potential for bloodletting here, and it's just not a closed loop system. So we're going to use a closed loop system. So as soon as you get this in, you're going to screw the drip set on, and we're going to kind of go from there.
The saline flush onto the catheter and then inject it. If the vein is indeed patent, it should slide easily out of the syringe and into the vein. This should not cause the patient any discomfort, and you are merely hydrating them. After the 10 mils are inside the patient, you have ensured that the vein is patent, and you now can attach your IV or a cap, whatever apparatus you want to. In this case, we're just simply going to remove our entire catheter and syringe in one fell swoop, and we will show you how to successfully remove a catheter. To do this, you'll need a 2x2 inch gauze pad, and you'll place it just proximal to where the catheter enters the skin. Applying pressure, you'll remove the catheter and syringe in one swoop, like so, applying pressure on the puncture site. You can now apply a bandage or tape this 2x2 in place.
That's really it. And then that syringe should have never you should never set it down. It should go straight into a sharps container. So that's the process. That's going to allow us to kind of skip ahead. Feel free to go back to that if you need to. There are hundreds and hundreds and hundreds of videos on YouTube on how to start an IV. But the big thing is how to secure it. There's a bunch of different ways, and we'll do all that in person. So let's go back to the awesome, incredible PowerPoint. I hate PowerPoint, by the way.
Adam, he didn't draw back once he started that. Is that not a thing anymore?
That's not a thing that we teach anymore. No. So what he's referring to is if you're in the right spot, if you're in the wrong spot, what you end up doing is, so if you're in the wrong spot and you start pushing fluid in, it's going to go into the interstitial space and not into the vein. And you're going to end up with this god awful looking golf ball that ends up building underneath the skin, because you're literally injecting all that fluid directly under the skin and not into the vascular system. So there's nowhere to go, just to accumulate there. Incredibly painful. Elderly people, everybody bruises for that matter, but elderly people, when you get them really, really god awful bruises, it lasts forever. That's just an accumulation of blood and everything else under the skin. Because again, when you do that, you've poked not only one, but usually you've poked two holes into one vein. So you've harpooned, you've gone all the way through both of them. And when you infiltrate the vein like that when you pull that needle out, blood flow can now start to accumulate under the skin also, because you've poked two holes in a vein. So now you have 10 mLs of fluid, or however much fluid it took before you noticed, oh God, that's terrible, and you stopped. You'll have that much fluid sitting in there. And in addition to that, you'll end up having the blood flow that's coming out of the actual vein that you just catheterized. So that's where all those god awful bruising and all that stuff comes from. So what Alex was talking about is when he hooked that syringe to it, if you pull back, you should get a blood flow because you're in a vein and you're literally just drawing blood out of the arm. That gives you an idea that you're physically in the vein, you're where you should go, and you can flush and you should be good to go. I still do that, and there's nothing wrong with physically doing that. The argument is if the catheter slides off into the vein, then you are where you should be. So no, it's not part of the curriculum anymore to actually teach that, but I like it still. So I'll draw back to make sure if I'm not in the vein, if I poked all the way through or something like that, and I draw back, I won't get anything. I won't get any kind of blood flow or anything into the syringe that I'm using. So that is a good point, and that is a good technique. It's just not something that they necessarily teach anymore. Okay, so we're going to skip all the way ahead. We're going to skip to some EJs. EJs in general are these are kind of nerve-wracking. So we're back to page 706. Nerve-wracking because there's some important stuff that lives in the neck. So a lot of people have a hard time just drumming up the courage to poke a needle anywhere inside of somebody's neck. This should be kind of a last ditch or a second to last ditch effort. This should be something that you absolutely need because you can't find anything peripherally. So to do this, generally you're going to lay them down on their back, lay them kind of flat. In some cases, you may have to elevate their feet, but semi-Fowlers and below is what the book will, or what the technical positioning should be. But the flatter they are, the more gravity is working with you, and ultimately the goal is to shunt blood to the head instead of to the feet with gravity. So again, these will kind of start to bulge out as this picture shows. So you're going to lay them kind of flat. You're going to let blood flow kind of return up to the head. You turn the patient's head a little bit. And a lot of times what I will do with these is I will take a finger on my non-dominant hand. And this is where it gets kind of weird. Obviously, you want to feel this and make sure there's not a pulse in this. You typically cannot see a carotid artery through the skin. That's baked down way low in here. So if it's superficial, it's going to be that external jugular vein. And there are times where I will take my non-dominant index finger way down here and occlude. And if I'm pushing down in here, it's going to allow this to kind of back up and kind of engorge a little bit. And that gives me a really, really good idea of where I'm poking. So I'll figure it out. I'll line it up like this person did, and then I'll let go. I'll pull the skin taut, which is something else that this picture is not showing. I'll grab somewhere in here and I'll pull towards the ear just to kind of make sure everything's nice and tight. And then I'll cannulate. I'll do the IV. So we'll talk a lot about this kind of stuff. The one thing that we're going to talk about specifically with this is one of the big problems that you can have, and some of the considerations that we'll talk about here in just a few, is introducing air into your blood system. That embolism, it's called an embolism. That embolism is fatal. It is fatal. So if you think about IV tubing, there's about 1 milliliter or so of fluid that actually fills up that entire tubing set. If you don't pre-flush that, so basically you poke in, you cannulate the actual bag, you poke in with the piercing spike, you fill up your drip chamber, and you never open that line up to drain all the air out of there and replace it with saline fluid. Once you open that up, you're literally pushing that full ml of air into the body, and again, that can be fatal. So we don't want to introduce any air at all. That's why we flush everything that we use for IV sets. You can't necessarily, you can flush it, but when you're doing this EJ vein, this EJ is directly tied to the vena cava, which is directly tied to the heart. So this is the most proximal, close to the heart you can get for any kind of vein cannulation. So it's not uncommon. As soon as you poke, you feed the catheter off. Once it's in here, I will let this drip a blood or two out if I can, just to ensure that there is no air whatsoever in any of this. So as long if I can let a drop or two of blood come out of this for an EJ, that like I said, in my mind, that tells me that this is 100% filled with fluid, and it's the patient's, it's blood. And then I'll pre-fill my drip set, and I'll plug the drip set in, knowing that that's already filled with saline fluid. So I'll plug that in, and then I know that I've got a closed, air-free system. And then we got to tape it down and secure it. Really, no other question. That's pretty straight line. We'll practice it. Here's some different catheters. This is pediatric considerations. Generally speaking, well, no, not generally. 100% of the time, this is something to know. The higher the number, the smaller the needle. The difference is there are different lengths. So some of these can be 2 inches. Some of these can go all the way down to 1/4 of an inch, very, very tiny, depending on what manufacturer you buy from and what type it actually is, or where it's from. So again, with kids, you're gonna live somewhere up here in the 22 to 24 gauge. The consideration to think about though is the smaller the tool you got here, the more flimsy this metal needle is. So these can absolutely bend over, and they can kind of crimp and break. So again, things to think about. If you've got a really frail older person, it's not uncommon for me to use a 22 gauge. The common sizes that you're going to use are 18, and 18 will be considered a large bore. So you'll hear that term a lot. Anything 18 and greater is considered a large bore IV. This is for very, very aggressive fluid management. So your trauma patient that's hypovolemic, you're going to want to introduce a lot of fluid at one time for fluid resuscitation, and you're going to need probably an 18 or greater. The 20 gauge is the most common. If you're not dying, this is what I stick in everybody, because again, the difference between this and this, you can visually see is great. But the difference between this and this is also great. So this, what I try to do, this 20 gauge, this is kind of a good balance between enough fluid and not super painful and not a big huge hole in somebody's vein. So I usually prefer these pink 20 gauge ones. There's older practitioners that think if you can't put an 18 in somebody, you shouldn't be in the field, and that's all garbage. So just remember 20 and 18 are the most common. If you don't think the vein, just looking at it, if you think it's a really, really tiny or really, really superficial, something close to the skin, it's not uncommon for us to fall back to a 22. But again, the difference between a 20 and a 22, the actual metal trochanter in here, the actual needle is really, really flimsy. So if you're trying to poke through, thick skin, sometimes you can bend this over if you're not careful. So there is a big difference. So again, 20 is that happy median for most practical uses. We talked about IV locations. The only other thing to think about, and I will show you guys this in person, with kids, if you go to Children's Hospital, there's a bunch of different tools that they use. There's an ultrasound. Well, all hospitals have an ultrasound system where they can actually scan the arm and look on a TV screen, and they've got the benefit of seeing where the veins live, especially if they're down underneath a couple layers of fat and you can't see them. That's good and bad. It'll tell you, yes, there's a vein there, but it doesn't tell you how deep it is or how shallow it is. So there's still some guesswork in trying to figure out where and how to physically cannulate that vein. With kids, a lot of times there's very, very little visible with kids. Sometimes you might see a color, like you'll see a blue line where the vein should be, but when you're feeling it, you're feeling for that rubber band. And if you can't feel that rubber band, which most kids you can't, a lot of it can kind of be sight. And like I said before, generally we don't like to do IVs by sight. Usually it's by feel, to make sure that it's a tolerable vein for us to use. What I will do, and what a lot of people will do, is they'll take a flashlight and they'll stick a flashlight physically on the skin, and you can kind of do this with yourself. If you pull your skin kind of tight, you can use a flashlight right on top of the skin, right on the surface of the skin, and you'll see red from your red blood cells that are in there, and then you'll also see little black channels, and those black channels are the veins. Kids, that works really, really well because kids don't have a lot of subcutaneous fat yet. So what they'll do in the hospital is they take a really, really bright light and they will stick it in the palm of the kid's hand, and they'll cup their hand around it, and they'll be able to see the red and the veins through the top. So it's not uncommon, if you guys do ride time with me or whatever, it's not uncommon for us to turn all the lights off in the back of the ambulance and get a flashlight out to try to find a vein under the skin. It's just a small, silly little trick, but they did mention it here specifically for peds. Conversely, the elderly patients, they're prone to bleeding, the veins are damaged, they're old. Tape may damage the skin when they rip it off. Bruising happens almost instantaneously. So the smaller the IV catheter with elderly people, the better. The two circumstances where we're gonna talk a lot about IV therapy and the sizes, specifically the sizes of the needles, is going to be trauma and stroke. So trauma and hypovolemia and all of that, you need a lot of fluid for somebody that's hemodynamically unstable. So you'll want to use an 18 or greater for these trauma patients, because again, that's aggressive fluid management. Stroke patients are somewhat similar. Stroke patients, they have to get that TPA. They got to get that medication to bust up the clot. That's a really, really thick serum that they use for that, and they generally want a bigger needle for that, and they usually want that as proximal as possible. So like down in the hand or the legs or the feet or something, they're not a big fan of those. They'll just start another one when you get in the ER. So trying to start it in the AC, that antecubital fossa area. And trying to keep it at least a 20 or bigger. They don't like trying to push TPA through a 22. So just some stuff to think about. Macro drips. This is talking about older people, and again, us dumping a lot of fluid into a weak vein all at one time. And we're not going to spend much time on that. So some of the factors that affect the flow, they talk about a couple different things here. Why is your So once we stick that IV in, once we connect our drip set to it, we want to take that little blue controller and we want to unroll it. We want to open it up and let it flow. What we're looking for is the drips to start coming out of the drip chamber. If you open it all the way, you may get a solid, steady flow of fluid. Specifically with the larger bore, you'll see a solid flow of fluid. If that's not happening, then there's a couple problems. Usually what ends up happening, and it's basically you just start at the bag and you just start tracing the system. So make sure there's no kink in the line, make sure the actual controller is open. You make it all the way through. Usually what ends up happening, there's a couple different things. On the very, very end of a drip set, there's usually that saline lock extension set that's already pre-built into most commercial drip sets. So it's essentially a drip set and a saline lock all in one system when you open it. So because it's two separate pieces that are already tied together for you, there's usually a clamp that will clamp off the saline lock down at the distal end of that IV tubing. So to make, again, you're just tracing your line to make sure everything's open. If you've made it all the way to the hub on the patient's skin and it's still not flowing, the second most common thing, and this ends up being probably the most common thing, is that when you stick that catheter down in somebody's arm, the catheter straightens up, it straightens out and goes kind of up into the vein, and that hub sticks straight up in the air. So really what you've done is you've created a 90-degree kink in that where that hub is. And a lot of times you can confirm that simply by pushing down on the hub, like pushing it down into their skin and watching and see it flow. That's typically the term that we use. The term typically it's just positional is what we'll say. So that basically means that under the right position, it will absolutely flow. So that's a positional IV. And there's ways to kind of fix that. We'll talk about that stuff later. But there are some, this is just basic troubleshooting. Infiltration. This is basically where you've poked all the way through and you've caused all kinds of problems in there. This infiltration, the only way you can fix it is to stop it. So you can't, once you poke all the way through, you can't just back out a little bit and then feed it through appropriately, because now you have blood flow that's kind of circling through that area. So you should not leave that in there once it's infiltrated, even though you can back it out a little bit and fix the problem. Because again, it needs pressure now, because just like blood loss anywhere on the outside of the body, it needs pressure to try to stop that. So occlusion is usually a couple different things can happen with occlusion. And again, these are all complications. There can be, if an IV catheter sits dormant and you're not running anything through it, the platelets, the whole job of the platelets are to create those clots for anything that's foreign. And that's exactly what it's going to do. It's going to occlude the end of that catheter and it's going to prevent any kind of blood flow. So when we hang a bag of fluid, we're going to set our drip rate to we're going to make sure that it's flowing during the entire transport, but we're not looking for a therapeutic effect. We're just looking to keep that vein open. We're just trying to keep that catheter open. So when we document that, if I give a whole 500 milliliter, bolus to somebody, I can document that I gave 500 milliliters. If I didn't want to give a whole bunch of fluid because the patient has congestive heart failure or whatever it is, and I don't want to give a bunch of fluids, I still have to run it in that keep vein open rate, which is basically just a drop every couple seconds. You just want to make sure that it's physically flowing, and you'll document that as TKO, which is to keep open. And that's the easiest way to kind of document that. So again, anytime you start an IV, you have to have something moving through it, or else it's going to clot itself off. And a lot of times it's just a drip every once in a while, just to make sure that it's physically flowing. Any questions on that? We talked about occlusion. Irritation is going to happen if you start slamming too much fluid too quickly. A lot of times you'll feel swelling, so you can kind of feel around the IV site. And if it starts to feel really, really rigid and firm or swollen or red or any of that stuff, it's time to pull that IV because something's happened. Phlebitis, thrombophlebitis we're now into some more serious stuff. So this is infection, local infection, and this is a huge issue. It's not an issue for you. It's going to be an issue for the patient in the hospital because of something that you did. And again, this is usually because of some kind of aseptic or some issue with your septic technique. So you didn't clean it appropriately, something like that. This equals a hospital admission and IV antibiotics. So that's a pretty huge deal. So again, this is very, very important that we clean our sites appropriately and that everything we do is using that aseptic technique. So it can absolutely be prevented, and this will absolutely come back to us. So we have to try really, really hard to keep everything clean and sterile. When we're going through doing the practical skills, it's going to be pretty easy to identify the problems. There's a cap on everything. As long as you don't uncap it until you're ready to use it, you're generally pretty good. Hematomas, this is what I was talking about before. Somebody poked somewhere in this poor wrist somewhere, and this could have been months ago easily, and this is no good. But that's the thing, and this is sometimes it's just inevitable. We can't prevent it, even though we're trying our best. An arterial puncture, nerve tendon damage. There's no way we can fix that. Nerves live everywhere under the skin. It is possible for them to have some kind of increased pain. At the end of it, if they're uncomfortable, you pull it. That's really what it's going to come down to. The arterial puncture, again, this is possible because all those things kind of live together. So and you'll know it right away because as soon as you connect your drip set, you'll see blood flow shoot up into the bag. It'll go all the way up, and the pressure, you'll actually see it start to backflow. So that's not always, that's pretty easy to identify. And again, it's no good. So as far as the system, and I'm going to try to push through some of this stuff, and then we'll shift gears and do something different. The pyrogenics. So again, you're given either room temperature. Now, if a body is somewhere between 96 and 98, 99 degrees, somewhere in there, and room temperature is 70 or 80 degrees inside that ambulance, that fluid that's been sitting there is 70 or 80 degrees. So even room temperature is hypothermic to the body. And that's really important to understand because we're giving a whole liter of fluid to somebody sometimes of room temperature saline, which room temperature 80 degrees, even 85, even 90 degree saline, that sounds warm. And in fact, it might actually even feel kind of warm to you when you're touching it. But again, if the body likes to be somewhere in the 98, 99 degree range, if you're flowing in 80, 90 degree water or fluid, that ultimately can create some issues. And then conversely, we do have saline warmers, and that's something else that we'll talk about down the line. For when and how to give warm saline. But if you're giving warm saline to an already hyperthermic patient, obviously that can create some issues. Air, there's overload. Again, we've given too much fluid. Air embolus, we've introduced air into the body. Again, no good at all. Sometimes this is big with kids. This vasovagal, vagal in general is somebody kind of having a momentary lapse of consciousness. You've stimulated the vagus nerve, and it basically puts the entire body into this parasympathetic response that's immediate. And a lot of times that's anxiety. So just simply somebody seeing their own blood, physically feeling the poke of that needle, sometimes they can pass out on you. And really it's just, it's benign. It's not going to hurt them as long as they're in a safe position of comfort. But this is all you can do. You give them some oxygen, just monitor vital signs, finish your IV, because when they're unconscious, that's okay. You can still get that in there. Catheter shear is basically going too shallow and using the needle to actually slice either through usually it's through the catheter. So that plastic covering that goes over the needle, if there's any distance, so if it's pushed off at all, if that catheter is pushed off the needle at all, when you poke, that needle is going to go right through the side of the catheter, and there's nothing you can do about it. You got to pull that. That's not going to work. We're going to talk real quick about some blood samples, real quick, because we don't really do much with this. There are, when you go to the hospital, when you're drawing blood, a lot of times they'll forego the they won't use a drip set. They won't use a saline lock. A lot of times they'll take a butterfly needle, they'll poke into the arm, and then on the other side of the butterfly needle, I think there's a photo of it somewhere here. They'll put these little, there's usually a little cup that has there's a small little needle inside here, and then they'll use these different vials to draw blood samples. There is not, they talk about this self-sealing blood tube, this whole section here. I don't know a reason that we need to know this. I've never once been asked this on National Registry, never once. And I don't foresee it being on any of our exams. So something to know. There are different tubes. These different tubes do different things. If you have an interest in nursing school, they go deeply into what these are. Like for example, like the red caps, they have no additives whatsoever. The whole intent of them is to let the blood kind of clot inside there in the tube. Blue, there's different chemicals within each one of these to do different things. The green one has heparin. So again, that's a tube that will keep the blood. It keeps it from coagulating. It keeps it from clotting up. So again, there's different things for different reasons, but a lot of this is all hospital based. There was a period where they had us doing blood labs for DUIs, which I strongly am against. I don't think we should be drawing blood for cops just because of all the previous slides talking about all the complications that can go into venous puncture in general. So to help them in court is not my job. So we don't typically do that anymore, but it's a thing. It's a thing somewhere else in the country. So just some things to think about. This is just how to physically do it. Again, the process is the same. You still put a tourniquet on, you still do your typical venous puncture. A lot of times, again, you're going to use a butterfly needle, and that butterfly needle on the other side of it is going to have, it's going to have this little green cup on it already. Blood transfusions. The only thing I need you to know about blood transfusions is that this hospital has O blood available for transfusion. O blood is going to be that's going to be the most common for us as far as the universal recipient. So that's pretty important for us to kind of know and understand. And that's really about it for that. So let's take 5 if we can, and then we're going to get into some IOs. And these are barbaric and brutal, and they're a ton of fun to do. So just take about 5, and we'll come back and we'll do this.